Welcome to the second part of our module on the clinical record. In this session, we will address three fundamental aspects: the ownership of the document, access to information, and the confidentiality of the data it contains. To begin, we must understand that the clinical record is much more than a bundle of papers or digital files. It is a legal, ethical, and clinical instrument that backs up the care provided and protects the patient's rights. But who is the actual owner of that record? Who decides what is done with its content? What regulations govern it? These are the essential questions we will answer today. One of the most critical points is to distinguish between two concepts: the property of the physical or digital document, which belongs to the institution or the physician who generates it, and the ownership or title of the information, which always belongs to the patient. This means that even if the hospital holds the file in its archives or system, the person has the right to know what is written about them, to request their information, and to demand that its confidentiality be protected. This topic is central not only to modern clinical practice, but also to the fundamental rights of patients in any health system. It is legally backed by NOM 004, which in Section 5.4 states literally, clinical records are the property of the institution or the medical service provider that generates them. The patient has ownership rights over the information for the protection of their health as well as for the protection of the confidentiality of their data. The bottom line: if we truly understand this foundation, we will know how to handle our patients' clinical information with responsibility, legality, and ethics. To better understand the legal framework of the clinical record, we must distinguish between two concepts that are often confused: the ownership of the document and the ownership of the information. Ownership refers to the physical or digital medium where medical care is recorded. In other words, the record as an object. This belongs to the health institution, the hospital, the clinic, or, in the case of private practice, the physician who generates it. But the content of the record, the diagnoses, procedures, and medical notes, belongs to the patient. That information belongs to them by right, because it speaks of their body, their health, and their life. Therefore, even though the institution holds custody of the record, it cannot freely dispose of the data. They cannot use it for unauthorized purposes or refuse to hand it over when the patient requests it. Unless an exceptional case is established by law, every use must be backed by consent or legal authority. This distinction is clearly outlined in NOM 004, Section 5.4. It establishes that the patient holds the title to the information contained within their clinical record. This means the patient can access their record, request corrections if there are errors, restrict its use, and demand that its confidentiality be maintained. As healthcare professionals, we must be very clear. Whoever generates the record safeguards it, but they do not possess exclusivity regarding the information. Let's think about this scenario. If a hospital refused to give you a copy of your record, claiming it belongs to them because they generated it, is that legally correct? The answer is no. As a patient, you have every right to access that information because it belongs to you. It is a right, not a courtesy. When we speak of the clinical record as a fundamental document in medical care, we must not forget that it is also the primary repository of sensitive personal data. For this reason, patients are recognized to have ARCO rights, which stand for access, rectification, cancellation, and opposition. These rights are enshrined in two main laws: the Federal Law on Protection of Personal Data held by private parties, which applies to private institutions, and the General Law on Protection of Personal Data held by obligated subjects, which applies to public institutions. Let's break them down. The right of access allows the patient to consult their entire clinical information and obtain a copy if they so request. The right of rectification guarantees that they can correct erroneous or incomplete data, for example, a mistaken diagnosis or a misspelled name. The right of cancellation allows the patient to request the deletion of data when it is no longer necessary, provided there is no legal obligation to preserve it. And the right of opposition empowers the patient to refuse the processing of their information in certain cases, such as for research or advertising purposes. Why does this matter? These rights strengthen the person's autonomy over their medical information. Their recognition becomes even more relevant when we understand that the clinical record is not just a medical registry, but also an expression of the right to health information and the protection of personal data. We know that official Mexican standards, NOMs, are mandatory. However, few people know that during their modification process, technical and legal comments are received from experts, institutions, and citizens. These comments are analyzed and answered by the regulatory authority in a public document, the Official Response to Comments. In the case of NOM-004, this response clarified a critical point. The standard does not impose limits on the patient's access to the information contained in their clinical record, nor is it the standard's place to establish the obligation to deliver copies, as that must be defined through laws of higher hierarchy. This is key. In Section 5.6 of NOM-004, it is established that health professionals are obligated to provide verbal information, and that the patient or their representative may request the clinical summary, resume in clinico, or other records in writing. A common misinterpretation. Some institutions interpret this mention of the clinical summary as if it were the only thing they are allowed to grant, but the text does not say that. By mentioning other records, otras constancias, it opens the possibility of delivering any document containing the patient's medical information. In other words, while it may not literally say full copy of the record, it does contemplate access to the information contained within it, provided it is formally requested. Legal reinforcement. This is reinforced by the regulation of the General Health Law regarding the provision of medical care services. Specifically, Articles 29 and 30 establish the duty to provide information on diagnosis, treatment, and prognosis, without restricting it solely to the summary. In summary, the NOM does not impose barriers. It is up to the organizations themselves to define the mechanisms to permit access to information. However, when doing so, they cannot contradict the rights established in data protection laws, nor in the General Health Law. Final reminder, as per Section 5.4 of NOM-004, the clinical record is the property of the institution or the medical service provider that generates it. However, the patient holds the title to the information it contains. As such, they may exercise their rights over it in accordance with the principles of confidentiality, access, and informational self-determination. We have already established that the patient holds the title to the information contained in their clinical record. However, there are legally authorized exceptions where third parties may access this information without the patient's express consent. These cases are delimited by NOM-004 SSA 32012 in Section 5.6, which states the following. Health professionals are obligated to provide verbal information to the patient, to whoever exercises parental authority, legal guardianship, legal representation, family members, or competent authorities. When a clinical summary or other records are required, it must be requested in writing. Competent authorities to request clinical records are judicial authorities, justice procurement bodies, and administrative authorities. This means that only the following figures may request the record directly, in writing, without needing the patient's authorization. 1. Judicial authorities, such as judges, strictly within the framework of a legal process. 2. Justice procurement bodies, such as prosecutors' offices, fiscalias, when investigating a possible crime or negligence. 3. Administrative authorities, such as COFEPRIS or state medical arbitration commissions, when performing sanitary surveillance or inspection functions. A crucial condition. In all these cases, access must be justified, proportional, and documented. It is not enough to submit a generic request. A clear legal cause must exist. Minors and incapacitated persons. Furthermore, when dealing with minors or legally incapacitated persons, their guardians or legal representatives possess full rights of access. A very frequent and often misunderstood case is that of insurance companies. These companies are not competent authorities, nor can they access the clinical record without the patient's consent. They can request it, but only if the patient has previously granted their authorization. How is this authorization usually given? Normally, it is found within the clauses of the contract signed at the moment the medical policy is purchased. However, it is highly recommended that the healthcare facility also obtain a specific authorization. This leaves an express record that the patient allows their clinical information to be shared with their insurer. Why is this distinction so important? Because in practice, the exact opposite often occurs. Sometimes, a patient requests their own record, and the hospital replies that they must ask the insurer for permission or request the file directly from the insurance company. That is incorrect. The record contains the patient's information, not the insurer's. The patient is the title holder and always has the right to access it. In summary, outside of the legal exceptions previously mentioned, no one, not family members, not employers, nor insurers, can consult or receive the clinical record without the patient's consent. The general rule is clear. Third-party access is not free. It is regulated. It only proceeds when there is a justified and duly documented legal cause. This regulation is not an obstacle. It is a guarantee. It protects privacy, prevents abuses, and recognizes that the clinical record is more than a medical document. It is the intimate history of a person's health and must be safeguarded with rigor, ethics, and respect. One of the strongest pillars sustaining the doctor-patient relationship is confidentiality. Without it, trust simply would not exist, and without trust, there cannot be safe or ethical medical care. The clinical record contains personal, sensitive, and often very intimate information. Therefore, it must be safeguarded with the highest possible level of discretion. What does this imply for us as healthcare professionals? First, professional secrecy. Everything the patient entrusts to us, or whatever is documented in their record, must remain protected. It cannot be discussed in hallways, published on social media, or shared with unauthorized persons. Second, prevention of unauthorized access. This includes simple but critical habits. Do not leave physical files in plain sight, do not share passwords for electronic systems, and do not allow third parties to read clinical notes without permission. Third, the obligation to protect data. We must protect personal data against risks such as theft, loss, or improper disclosure. This applies equally to both the physical and the digital record. The consequences. If we fail to meet these responsibilities, the consequences can be severe. We may face administrative sanctions, lawsuits for moral damages, or even criminal proceedings if the violation is grave. A universal duty. Crucially, this obligation does not fall solely on the physician. All health personnel are subject to this principle. Nursing staff, administrators, technicians, students, no one is exempt. Let's reflect on a case. What responsibility would a medical intern bear if they uploaded a photo of a file with the patient's name visible to social media? The answer is clear. They have committed a grave ethical fault and possibly a crime, even if they had no malicious intent. The bottom line, confidentiality is not broken by bad intentions, but neither is it justified by good ones. It can only be lifted by an express legal mandate. So far, we have discussed patient rights and the obligations of healthcare staff, but there is another fundamental actor in this topic, the health institution itself. Public and private hospitals, as well as clinics and private offices, have a legal and institutional obligation. They must safeguard clinical records under conditions that guarantee their integrity, confidentiality, and availability. What does this imply in practice? First, secure storage systems. Whether physical or digital, records cannot simply be piled up on just any shelf, nor stored on personal devices without backups. Second, clear and effective access controls. This means that only authorized personnel may consult them, and strictly for clinical, administrative, or legal purposes. Third, defined institutional policies. There must be clear rules on how a record is consulted, lent out, copied, preserved, or even destroyed. Fourth, periodic training. Staff must be trained regularly on the importance of these measures and how to apply good documentary practices. These actions are not optional. They do not depend on the resources or the size of the institution. They are regulatory requirements established in NOM 004, Section 5.7. Let's look at it this way. Safeguarding a record properly is not simply about archiving it. It is about protecting a right, preserving a clinical history, and guaranteeing the legal security of both the physician and the patient. Imagine a scenario. A hospital loses hundreds of clinical records during a move and has no digital backup. What consequences could they face? Everything from administrative sanctions to legal lawsuits, and certainly a profound loss of institutional trust. The bottom line, we must be clear that protecting the clinical record is also protecting the dignity and rights of the people we serve. We live in a digital era, and this has transformed how medical care is documented. The clinical record is no longer just stored on paper. Today, it is also registered on electronic platforms. But with these advances come new responsibilities. The electronic clinical record, or ECE, must meet the exact same requirements as the physical record. It must be complete, confidential, available only to authorized personnel, and adequately safeguarded. However, it demands specific digital security measures, such as user authentication, to prevent unauthorized access and modification logs, to know exactly who viewed or changed which information, backup and recovery protocols, in case data is lost or technical failures occur, and very importantly, continuous training for the staff managing these systems. Why is this so important? Because the risks have also changed. We now face cyber attacks, identity theft, and data manipulation. If information is not well protected, the damage can be severe, and not just legal, but clinical and human. And here, it is useful to remember a key idea. Digitalization does not eliminate responsibility. It only changes the way we protect it. Let's think about a very real case. A physician leaves their session open on a shared computer, and another user accesses a patient's record. Who is responsible if confidentiality is breached? The system might be new, but the responsibility remains with the professional who failed to protect their access. The bottom line. So, even if we possess state-of-the-art technology, ethical and legal care remains in our hands. The clinical record does not disappear when medical care ends. In fact, its value may increase over time, especially if doubts, complaints, or legal situations arise later. For this reason, it is mandatory to preserve it for a minimum period, even if the patient is no longer under active follow-up. According to NOM 004, SSA 3 2012, in Section 5.4, records must be safeguarded for at least 5 years, counting from the date of the last medical act. However, while the law establishes this 5-year minimum, there are special situations that justify extending this period, even if not expressly mandated by the standard, except in legal cases where the file cannot be closed or destroyed until the authority permits. Therefore, the following are considered best practices for prolonged retention. For pediatric records, it is suggested to keep them at least until the patient reaches legal age, and from that moment on, maintain them for an additional 5 years. For patients with psychiatric disorders or chronic diseases, it is recommended to keep the record for a broader time frame, considering its long-term medical relevance. If the record is involved in a legal process, audit, or administrative investigation, it must be preserved until said process formally concludes, regardless of the time this implies. These recommendations guarantee not only the legal and administrative security of the establishment, but also the patient's right to access their clinical information in a timely and complete manner. Furthermore, disposal must be secure and documented. It is not enough to throw it in the trash or simply delete a file. You must ensure that the information cannot be recovered to protect the patient's confidentiality. Let's remember this concept. The clinical archive is also a form of care. Even when the patient is no longer present, the record continues to fulfill a function, protecting them and backing the professional. Imagine this scenario. A patient returns 6 years later with a complaint about poor care, but the record was destroyed without any log or register. What defense does the physician or institution have? Practically none. The bottom line? Preserving the record well is not a luxury nor a bureaucratic formality. It is a tool for legal, ethical, and professional protection. Up to this point, we have discussed obligations, principles, rights, and best practices. But what happens when those obligations are not met? Mishandling the clinical record can have grave legal consequences, both for health institutions and for individual healthcare professionals. These consequences fall into 4 main categories. First, administrative sanctions. Health authorities can impose fines, suspensions, and even temporary closures if they detect non-compliance with guidelines regarding safekeeping, confidentiality, or conservation. Second, civil liability. If the mishandling of the record causes harm to the patient, for example, if sensitive information is leaked, evidence of care is lost, or access to their history is impeded, lawsuits for moral or patrimonial damages may follow. Third, criminal liability. In severe cases, such as the intentional disclosure of data or the misuse of the record for personal or commercial gain, the professional may face criminal proceedings. These can result in economic sanctions and even imprisonment. Fourth, ethical or disciplinary sanctions. These can be imposed by medical colleges, ethics committees, or educational institutions. They range from formal reprimands to the suspension of professional practice. These consequences apply in situations such as denying the patient's legitimate access to their record, losing or destroying records without backup or documentation, disclosing information without consent, failing to adequately protect access to physical or electronic files. We can summarize it this way. Failing to protect the clinical record can be just as serious as failing to provide good care. Let's imagine a scenario. A clinic mistakenly hands a patient's record to another person with a similar name. What consequences could follow? Everything from a lawsuit for violation of privacy to a complete loss of institutional trust. The bottom line, therefore, the clinical record must be handled with the same care we apply when performing a medical procedure. It is part of the care and of professional responsibility. We have reached the end of this session, and with everything we have reviewed, it is important that we do not limit ourselves to merely norms and obligations. What truly matters is understanding the profound meaning of the clinical record in medical practice. The record is a document, yes, but it is also a tangible representation of the doctor-patient relationship, and as such, it must be treated with respect, care, and responsibility. Let us remember 3 key ideas. First, the document is the property of the institution or the physician, but the information belongs to the patient. This difference is not merely technical. It is ethical and legal. It means the patient has a voice, has rights, and must have control over their own clinical history. Second, access to the record must be guaranteed. It cannot be conditioned, delayed, or denied without legal cause. To prevent a person from accessing their health information is to violate their right to decide and participate in their own care. And third, confidentiality is non-negotiable. It is the foundation of trust. If the patient does not feel protected, If they do not have the certainty that what they share will be safeguarded, that therapeutic relationship breaks. A final thought. Protecting the clinical record is not just a professional obligation. It is also an opportunity to dignify medicine, to practice it with humanity, transparency, and justice. And so, I want to close with a rhetorical question. Every time we protect the clinical record, aren't we also caring for a relationship of trust and a human right? That is the true essence of this topic.